Ya salam. Kushi tamam. Mahsud Nasari. Welcome back to year 3. Got a little bit of echo here. Is that better? Okay. So welcome back to the best course of the year, right? Your clinical skills, your communication skills. And we're going to do something slightly different this semester. So we're trying something out new, and we want your feedback. It's a lot of vibration. Is that better? Yes. Awesome. Okay. So what we're going to do is we're going to give you an hour of theory, in a lecture and a demonstration, and then we're going to give you another hour for you to practice the skills. So next week, having watched this video many times, you're going to have a go yourselves, and we'll all be available, all the staff, and you'll split up into small groups and we practice the skill. So that makes sense. We'll give you an hour of theory, and then you'll get an hour later on to practice the history taking or the clinical skill that we're teaching or the procedure. So we're excited to try this new method, and tell us what you think. So today we're going to look at the thyroid, how to examine the thyroid, and the diabetic foot examination, because you're doing the endocrine module at the moment, right? Okay. So we're going to quickly go over a quick review of the anatomy and physiology. Is it the phone? No, it's not the phone. Right, try again. So we're going to quickly review the anatomy and physiology of the thyroid glands, then we're going to review the symptoms and signs of thyroid disease, moving on to giving you a systematic approach to looking at the thyroid glands. Then we're going to move on to the diabetic foot, quickly look at the pathophysiology of what happens, and then a systematic review of how you examine a diabetic foot. Does that sound okay? Kushi tamam? Okay. So if you all just feel your chin, and with your finger follow down in the midline, you get the hyoid bone here, then you get to the Adam's apple, yeah? Quite prominent, particularly in males. And then just below there you've got a little gap, and then you've got your cricoid cartilage. Just below this, you can feel your trachea, and this is where the bridge, or the isthmus of the thyroid gland sits. And you've got the two lobes on either side. So you feel down, feel the Adam's apples below there, there's a little gap, then there's another bony prominence, the cricoid cartilage, and just below that is the isthmus, the bridge of the thyroid gland. And the lateral borders are just tell me if I'm moving away from the camera. I tend to move around, so just tell me if I'm out of the shot of the camera. Okay, push your quotes. Okay. So here you've got the isthmus, the two lobes, the left lobe and the right lobe of the thyroid, and the lateral borders are present with the common carotid artery, the right common carotid artery and the left common carotid artery. And the branches of this supply the thyroid gland. Try this way around. Okay. Quick review of the physiology. So you've got the hypothalamus secretes TRH, thyrotropin releasing hormone, which then acts on the pituitary to release thyroid stimulating hormone, the anterior pituitary gland. That in turn then stimulates the thyroid gland to produce T4. Okay, T4 then gets converted in the liver to T3, so the TRH to the pituitary TSH, then stimulates the thyroid gland to produce thyroxine, gets converted from T4 to T3 in the liver, and then that works on the rest of the body. It works on the heart, increase the heart rate, increase the metabolism, affects bone growth and muscle growth as well. So that's just a quick overview of the thyroid hormones. So over to you, the audience. If you've got somebody who's underactive, hypothyroid, what happens to the TSH? Does it go up or down? So hands up for up, and hands up for down. A few at the back, brave souls. Okay, what about the T3 and T4 levels? Up or down? Normal. So usually goes down, yeah? Because your thyroid gland is not making enough thyroxine. It's hypothyroid, underactive. And so that stimulates the pituitary and the hypothalamus to produce more TRH and TSH to activate the thyroid gland to make more. So it goes up because it's trying to make the thyroid glands work more to produce more thyroxine. So what happens with a hypothyroid person that are overactive? What happens to their TSH? Up or down? Down. Down. And TS3 and TS4? Okay. So exactly that. You've got the negative feedback loop. So if you've got high levels of thyroxine in the bloodstream, that goes back to the hypothalamus and pituitary and knocks down the TSH. And therefore, trying to reduce the levels of thyroxine the thyroid gland is trying to produce. So these guys over here, give me a symptom of hypothyroidism, underactive thyroid gland. Just one person. Talk amongst yourselves. Give me one symptom. Can't hear you. We'll come back to you. What about you guys in the middle? Give me a symptom of hypothyroidism. So a symptom is different from a sign. Yeah, you know the difference between a symptom and a sign? A symptom is something a patient will tell you. A sign is something a doctor sees or finds. Okay? So what will a patient tell you if they're hypothyroid? Okay. Obesity. So they may gain weight. Yeah, so they may become more obese if they are overweight. Yeah? Tiredness, absolutely. Fatigue, number one symptom. It's one of the top 5 symptoms.
Weakness.
Weakness, maybe if it's severe muscle weakness. Yes, ladies over here. Cold. So, do they have a cold intolerance or a heat intolerance? Yeah, cold intolerance, absolutely. Yeah, good. Any other symptoms? Unconsciousness. Unconsciousness. If it's very severe, myxedema maybe, yes, it's rare. Yeah. So you've got tiredness and fatigue. They may have difficulties with their memory. They have problems with their mood maybe. Particularly the elderly, if they've got a memory difficulty, you should always check the thyroid function test. They may gain weight, as someone said. You may notice the neck swelling in the neck. A goiter. The voice may change, maybe more hoarse, a bit like me right now. The face becomes more puffy, particularly around the eyes. Preorbital. Sorry about this, guys. Maybe that's better. Also, when you check the palms, they've got dry skin. Yeah. Hair loss as well from the scalp or from the outer third of the eyebrows. The outer third, not the inner 2/3, the outer third. And cold intolerance, as you said. Brilliant. Everything slows down. When you're hypothyroid, everything slows down, including your bowels, so you get constipated. And also, for women, you know, you may get heavy periods, or if somebody comes to you with infertility problems, it's good to check the thyroid function test. And also, for the first time somebody has a cholesterol that's high, you should always check the thyroid function test, because basically it's a cause of hypercholesterolemia. So you may decide to treat this hypercholesterolemia, but actually they have hypothyroidism. So you should always treat the hypothyroidism first before you treat the hypercholesterolemia. And then recheck the cholesterol after maybe 8 weeks, 3 months, and see whether it's gone back to normal. Don't make the mistake of just treating a cholesterol isolated by itself. So hypothyroidism, talked about the different symptoms the patient may present with, but the signs that a doctor may pick up, they may notice that their pulse is slow. Everything slows down. The pulse becomes slower, the cardiac output's less, even the reflexes become slower. They become hyporeflexive. They may have coldness in the extremities. The swelling of the fingers may also affect the wrist, where the median nerve comes in. That's called carpal tunnel syndrome. Yeah? Particularly in women. And yeah, you may notice the weight gain, so you want to check the weight when you first see them. If they complain about breathlessness, you may just want to check there's no pleural effusion. Again, if they talk about abdominal swelling, they may be constipated, but they may also have fluid in the abdomen. So you may want to just check for a shift in dullness when you do an abdominal check. So those are the signs that you're looking for with hypothyroidism. What about hyperthyroidism? The commonest cause of this is Graves' disease. The commonest cause for hypothyroidism was autoimmune Hashimoto's disease, where the body attacks itself. You can check it with the autoantibodies, the EPO levels. So yeah, Graves' disease is the most common cause of hypothyroidism. Again, you guys start with the symptom form, hypothyroidism.
Sweating.
Sweating. The opposite of dry skin, sweating. Great. Guys?
Weight loss.
Weight loss. So the opposite, weight gain, weight loss. Yeah? Which one? Brandy or tachy? Tachycardia, yes. Everything gets faster. Okay? Yeah?
High temperature. High temperature.
High temperature. So they hate the heat. They're stripping off, getting all the clothes off because they don't want to be in a hot environment. Yeah?
Bone fracture. Bone fracture.
Bone
Fracture.
fracture. So it sort of does happen with the bones, because we talked about the thyroid hormone affecting the muscles and the bones. You can get what's called a periostal reaction, so you get increased bone. It's a problem with younger children particularly as well, because they may have fusion of the bones too early because there's increased growth. It affects the growth hormone as well. Okay. Yeah, excessive tiredness, not because they're very lethargic, because they're not getting sleep. They're very agitated, very on edge, very nervous. They also may get a neck swelling, a goiter. They also may tell you about eye symptoms. So notice the eyes bulging out. They may notice that they have double vision, particularly looking in certain directions, or it's just there all the time because the eyeballs got so big. They may have a painful red eye, like conjunctivitis. They also may describe being on edge and noticing the hands tremor. And like he says, they have increased appetite, but they're not gaining weight. They're losing weight, even though they eat like horses. And then again, we talk about heat intolerance, excessive sweating, and muscle weakness is actually a sign of hypothyroidism as opposed to hypothyroidism. So everything gets faster, including the bowels, so they have more frequency with the bowel motions, although that's less common. And then irregular or no periods in women can occur. So when you're looking at somebody with hypothyroidism, you may notice proximal muscle wasting. The hair is less, it's finer, it's less thick. They've got apothalamus, protruding eye. They've got maybe a neck swelling. They're sweating. They're tachycardia when you check the pulse. They may also have a high blood pressure in hypothyroidism. Again, you may notice weight loss, and when you check for tremor, they may have tremor as well. Okay? So, just to summarise, everything slows down in hypothyroidism. Slower pulse, bradycardia. What's bradycardia? What's the pulse rate of bradycardia? Less than 60. Okay, great. Slow metabolism, but they're gaining weight. Slower bowels, constipated. Slower reflexes, hyperreflexia. Hypothyroidism, everything gets a lot quicker. Faster pulse, faster metabolism, they're losing weight despite eating a lot, faster bowels, more frequency, and faster reflexes when you test the reflexes. Push it to Mark. Mark Masada. Okay, so we're going to do a thyroid examination. So I've got a volunteer. Would my volunteer please come forward? Who is my volunteer? Thank you very much. What needs to be just so. do you want me to stand? Okay. So I come down here then, is that okay? So, I've got your thing, sorry. Muthana. So this is Muthana. Thank you very much, Muthana, for this. So I'm going to do the usual introduction. You know, my name is Dr. David. Nice to meet you, Muthana. Also, I washed my hands beforehand. I've got no sink here today. And it's okay if you examine your thyroid glands. So your thyroid is in the neck. So I just need to expose your neck. Maybe just one more button. Yeah. And just to see the neck. We also are going to check his hands, his wrists, and then his eyes and neck, and we may do some other things as well in a thyroid examination. So I'm just going to look at Muthana first of all, his general appearance. What does he look like? Does it look like a man on edge? Or he seems quite relaxed? He seems relaxed, I think. But also with someone who's hyperthyroid, their emotions may be a little bit slower. You know, they're not as responsive in a smile and just a bit more slow in their reactions. They also may look tired, you know. He's had a difficult night last night. You want to check his weight. You know, as he's lost weight, as he gained weight in the last few months, last few weeks, what's happening with his weight. Again, you're going to check his hands now. So you're going to check his hands, you're going to look for finger swelling. And you're also going to look for any wrist swelling, particularly over the medial nerve as it comes in, over the carpal tunnel area. At the same time, you're going to, you may test it if you describe your symptoms. With a median nerve, obstruction or palsy, what do you get? With a median nerve, carpal tunnel syndrome, what do patients complain of? So they talk about tingling and numbness of which fingers? Median nerve. Median middle, okay? So in the middle, and these three fingers particularly, the index, you know, middle finger and ring finger. Sometimes half of the little finger as well. So tingling and numbness, then you may want to check for carpal tunnel syndrome. How do you check for that? Tinel sign, yeah? So you may hyperextend the wrist and then just tap on that area, okay? And ask them whether they get any tingling or numbness in that distribution, okay? And you may do that for half a minute. So if they complain about tingling and numbness, you may just check for that. The other thing you want to do is just check for the palms. So you're going to look over, is there any redness? What would the redness signify? So palmar erythema, redness of the palm, palmar erythema, hypo or hyperthyroidism? Hyper, okay? The other thing is it dry or is it wet? You know, is it sweaty or is it dry skin when you check his palm? And then we're going to also just ask to look for tremor. How do you check for tremor? Right, so you can do that or you can do that. So fine tremor, when you're looking for fine tremor, you put your hands out in front of you and you may put a piece of paper on top of it. Okay, great. Just to see if there's any fine tremor. Like, how nervous is Muthana feeling right now? It's okay, isn't it? That's great, thanks. So that's checking for fine tremor. And then I'm going to check his pulse. Okay? So I'm going to check my three fingers over the pulse. And I'm checking for what with the pulse? Two things. The rate. So whether it's got bradycardia or it's normal or tachycardia. Tachycardia is over 100. And what's the other thing I'm checking for? Rhythm. Why? Okay, what's the condition? Atrial fibrillation. So if you get an irregular rhythm or an irregular rhythm with atrial fibrillation. So you can get two types of arrhythmias. You can get irregular with a pattern. You may go duh, 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 duh. Catch up again. So you may have a pattern or there's no pattern. It's irregular. Okay, that's atrial fibrillation, like you know, there's no pattern whatsoever to it. Atrial fibrillation, okay? Then you may check if you're worried about hypothyroidism and the blood pressure, you know, if it's raised sometimes in hypothyroidism. And then I'm going to come to the eyes, okay? So, just going to move on to the next slide. Oh, these are just some slides to show you palmar erythema. Here you also get swelling of the digits, and what's this at the fingertips? Clubbing. How do you check for clubbing? Two middle fingers, and what should you see normally? A diamond shape, yeah. So if clubbing, you lose that, and you get like, you know, the curvature over the end of the nail. This is a condition called, go back again, called acropatchy. Acropatchy is three things going on here. So you get swelling of the digits, you get clubbing, and you also get this periostal reaction. So I was talking about the bones earlier. So periostal reaction, just see the whiteness of the bones there in the phalanx. Yeah, that's the periostal reaction. Okay, you sometimes see that too. So we've moved on from the hands, blood pressure. Now we're going to look at the eyes. And we're going to look at the eyes from two angles. We're going to look at from the lateral approach and from on top as well. So I may just ask Muthana just to move your head slightly backwards, and then we'll look over the top for any protrusion. Okay, does the eyeball come out from the eye socket? I'm also going to look from the side. Is there any, relax again. Just is any protrusion from the side, the lateral aspect. When I'm looking at the eye, I'm also looking at the conjunctiva. Is there any redness, any conjunctivitis? Then I'm also looking for periorbital, around the orbit, periorbital swelling all the way around the eye. And then I may test for double vision, diplopia. How do you test for double vision? Okay, yeah. With your fingers fine. I actually have a red spot as well. And you're going to usually ask them in the English letter H to follow that distribution. Now there's different grading of diplopia. You've got 0, no diplopia, to 3, where you may have diplopia just is relaxing rest, you know, just even looking up now he's got diplopia, that's grade 3. But you're looking to see if he's got grade 1 or 2. You know, is it on the lateral extreme or the upward gaze that he gets diplopia? So that's what we're testing for now. So, Muthana, if you just look at my eyes, you need to be the same level as the patient, and just follow the red dot for me. So I'm just making the H, and just tell me if you see double at any point when I'm doing this. Do you see double at any point in your gaze? Okay, so that's the H, you know, just check the diplopia. Okay? Lid retraction. What's lid retraction? So the eyeballs got so big that the eyelids have gone backwards. You know, you can't fit over the eyeball because it's got too big. That's lid retraction. What's lid lag? Do you know the English word for lagging, behind? So, you know, you're all walking as a group, and some people walk faster than others, and some people a bit slower. They lag behind the others. They lag behind. So, when you're testing for lid lag, you're asking the patient to follow my finger, and Muthana thankfully is normal, and his eyelid follows my finger at the same time as his eyeball moves. But if his eyelid lags behind, then it doesn't move at the same rate as the eyeball, and it stays up before, you know, longer. It doesn't follow down with the finger. Does that make sense? It lags behind. Okay. So here's some examples of proptosis, like the, you know, shocked look. You've got periorbital swelling around here as well. That's the lateral view. You see almost like a triangle coming out. Here is the conjunctivitis, the redness of the eye is often quite painful with chemiosis, which is like swelling of the conjunctiva. This is the lid lag I was talking about. That's normal. So as they follow down, the eyelid follows the iris. Yeah? With lid lag, it still stays up, even though the eyeballs move down. This is what? Hair loss in the outer third of the eyebrow. I think this gentleman's got some hair loss here as well, probably. Okay, so that's just about the eye. Okay, now we're going to move on to inspection of the thyroid. We're going to look at the thyroid. So we're going to do inspection, we're going to do palpation, percussion, and auscultation. Okay? So when you're inspecting, you want to make sure it's well exposed so you can see the thyroid glands. Then you're going to look from the front. Really should be able to see right into the cervical areas, anterior and posterior triangles. And you're looking for any lumps. What else may you be looking for? Scars from previous surgery. Anything else? Okay, lymph glands as well, just mentioned that. Yeah. And obviously the avoid thyroid spine, and then nodules on that. So we haven't got a glass of water, but I don't know if someone can get a glass of water, is that possible? Or then you've got a drink. That'd be great, thank you. Okay, so what we're going to do is ask you to swallow, and it's easy with a glass of water. You can do it once without a glass of water, but after that you always need a glass of water. Okay, so we're going to ask Muthana to swallow. And I'm looking at the side of his neck. If I've seen a lump, it'll go up once he swallows. Okay, that's great. And then, and then you're going to ask him to stick his tongue out, to protrude his tongue. So you can just do that for me, Nathaniel? Stick your tongue out. Okay, why do we do that? If you see a lump in the midline, and you think, right, now I need to ask him to protrude his tongue, why? The glands are connected to the tongue. Yeah, it's something connected to the tongue. Will the thyroid move with moving the tongue out? Will it move? No, it won't move. Yeah, so the thyroid stays put, it stays where it is. But another condition called a thyroglossal cyst will move with the tongue. So if you see something in the midline and it moves with the tongue, that could be a thyroglossal cyst. That's from embryology. It's how the thyroid gland develops in the embryo, in utero, and it comes down. So there's a remnant, a leftover part, and that's a thyroglossal cyst. That's where you get a lot of cysts in the midline, all through the body, because of the embryology of that. Okay, so then we're going to move on to palpation. So I'm going to ask first of all, have you got any pain at all in your neck? So if the patient's got an abscess or an infection, you want to make sure you don't cause any harm, or even a big goiter, they can be quite painful. And I'm going to come from the back. I'm going to just check my landmark's going to come down, feel the Adam's apple come down a bit further, and there's a trichoroidal cartilage, and just here. Now I'm going to put my two hands together, they're going to meet in the midline. And I'm going to keep my fingers flat. Yeah? I'm feeling with the pads of my fingers, not my fingertips, with the pads of the fingers. And I'm going to keep them together, they're going to meet in the midline, particularly these two fingers, the index and middle finger, but often people use all three. So you're going to feel for the landmarks go down, and checking for what? Swelling? Yeah? Why am I doing both together? Yeah, symmetry, absolutely. Is it symmetrical? Is there one swelling more on the right lobe, or is it global? Is it everywhere? Does it feel the same? If there's more than one lump, is it just unilateral on one side, or is it multinodular? Is there many lumps in the two parts of the thyroid glands? Okay, and then I'm going to move on from doing my thyroid check. So you may describe the size of the lump, you may describe how it feels, is it nodular, is it diffuse, how big is it, where it is. But then you're also going to just check the cervical lymph glands as well. So you're just going to quickly go around the different triangles. Anteriorly, and go posteriorly. Back up behind the ear, yeah? So you check both sides, the anterior and posterior cervical triangles for lymphadenopathy. What condition would you be worried about if you had a lymph gland and a thyroid lump? Pumpkin, yeah, maybe infection, but more worrying? Cancer. Okay, and then at the same time, I forgot to do this actually, was just to ask him to take another drink as you examine. So, so as you palpate, also ask him to drink at the same time, just to see if there's a... That's it. Just see if it moves with your fingers. You can feel it moving in the thyroid gland. The also other thing is you may check for thrills. What's a thrill? It's not something at the fairground. Yes. It's something you feel under your fingers. It's a vascular sort of, it's increased vascularization. So you can sometimes feel it at the heart, but often you can feel it on the neck if there's a lot of blood supply to a goiter, for example. And then we talked about adenopathy, checking for that. So these are some examples of some thyroid lumps. Here we have a woman with global goiters, both lobes. She's hyperthyroid likely. She's a black lady, so she's likely to have Graves' disease. There we have a unilateral lump on the right lobe, quite nodular, probably about 3 by 2 centimeters, quite prominent. Here we've got an Indian lady with multiple nodules, multinodular goiter. Yeah, and this is more subtle, it's quite subtle. See that? Just a slight subtle swelling just on the left. So then we're going to move on to percussion. So percussion. Why are we doing percussion? We're checking for enlargement of the thyroid glands. The thyroid gland can go below the sternum. So yeah, percussion. So we're checking whether they've got big thymus, basically. So start from just above the supraclavicular joint, so you go down to the sternum. Just if there's an enlarged gland, so you go. Because normally you hear a nice hollow sound with the air underneath of the lung, but if it's dull, there may be an enlarged gland underneath. Then you're going to auscultate, so quickly get your stethoscope, and it doesn't matter if you use your diaphragm or your bell, you can use either. I tend to use my bell, and just listen, take a deep breath in, hold it there, breathe away. Same again, deep breath in, hold it there, listen for a few seconds, can I hear a brewing? Shh, 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 increase vascularity again. You basically now finished the examination. Can I hear a brew? But if you find some signs of hypo or hypothyroidism, you may check for one or two other things. You may just check the reflexes, if they're brisk or not, just quickly with a tendon hammer on both sides. And then hypo-reflexive, a bit slow, or then hypo-reflexive, very fast. Again, you may just check for cardiomegaly if you find hypothyroidism, and it's been going on for a long time. So you just check where should the heart be, the apex be. Fifth intercostal space in the what line? Brilliant. Okay, but if it's deviated, you're looking for cardiomegaly. Again, if you're talking about breathlessness or an abdominal swelling, you may just check for pleural effusion by listening and tapping. Again, just checking for shifting illness in the abdomen. And then pre-tibial swelling is just in hypothyroidism on the shin, you can get some swelling as well. So it's just the last thing you might want to check. And then pre-tibial swelling is just in hypothyroidism on the shin, you can get some swelling as well. So it's just the last thing you might want to check. Yes. Again, like swelling of any tissue in the hand, it's because of hypothyroid, underactive thyroid. So you just get swelling of the tissues from that. Yeah. So thyroid cancer, again, just be aware of thyroid cancer. If you find a thyroid lump, could this be thyroid cancer? Now, it's not that common. It's probably maybe only 5% of all thyroid lumps. But if they're under the age of 20 or over the age of 70, think, could this be thyroid cancer? And you want to get an ultrasound scan and a needle biopsy. So red flag features of that include a child with a nodule, if they've had a change in the voice and more halts, particularly the goiter, that needs an urgent referral. A painless mass that's suddenly enlarging, over a few weeks, not over months or years. Now, in Jordan, I think the population is about 6-7 million, I can't quite remember now. About that. So in Jordan, you'll have about 400,000 people with thyroid disease. Now, I suspect 400,000 people have not been found to have thyroid disease because it goes unnoticed. Hypothyroidism is very slow onset, it's often missed, and not checked for. So yeah, palpable cervical lymphadenopathy, that's why you check for that, just to see if there's any possible spread of cancer. If they've got family history, previous irradiation, either from cancer treatment or for hypothyroidism, they're at risk, or maybe their job exposes them to that. Or persistent neck pain that lasts several weeks. Okay. They're all considerations with red flag symptoms to refer urgently for ultrasound and biopsy. How are we doing? Okay, you need a little stand up, a little stretch. Before moving on to the diabetic foot. Let's have a quick drink. What's that something? Okay, that's fine. So, people with diabetes. So, we're going to talk a bit about specific foot examination. Think about your osteotomy. Now this happens because of the process of diabetes. It affects the nerves and the arteries. So you can get neuropathy, high blood sugars, hypertension, hypercholesterolemia, all these things affect the risk of having neuropathy and ischemia. Or it can be a mixture in the foot of both of these things going on. So you've got three different nerves. You've got your motor, sensory and autonomic nerve fibres, and these all may be affected in diabetes, and they all have a slightly different effect on the risk of developing foot problems. So if you've got no sensation, you've got no protection. You're not aware, for example, you've got new shoes, you're not aware of it rubbing against your foot. You don't feel the pressure of it. Or when you're putting your feet by the fire in winter, you don't feel the sensation of heat, and you quickly, you get a burn. You're not aware of those sensations. The motor fibres, they affect the muscles and the bones. So if you've got a motor nerve problem, that can lead to induced stress. You kind of get an overarching of the foot, or like a claw toes as well. Or it can affect this other condition called Charcot's foot, where you lose the architecture of the foot. If you've got an absence of pain, that also contributes to the Charcot foot problem, and that's basically a degeneration of the ankle joint with the metatarsals. So you kind of have osteoporosis going on, you have thinning of the bones that can lead to fractures, and the joint itself collapses. So you get often quite a flat foot. You lose the arch, and you get like a redness around the dorsum of the foot, and then there's a pressure point underneath where ulcers can form. That's Charcot's foot, particularly in diabetes. We want to screen for that too. Why is this important? Why do we want you to consider diabetic foot examinations? Well, quite a lot of people will get a foot ulcer in their lives if they've got diabetes. 1 out of 10 will get a foot ulcer. In the UK, it's probably about 10%, but I think in Jordan I looked at the figures about 15%. Again, painful diabetic neuropathy affects, depending which country you're in, between 5 to 25% of people with diabetes. So, this is a painful condition. We want to screen for neuropathy before it becomes painful for the patient. The commonest cause of amputation that's not due to trauma is diabetes. And 80% of these people who go on to have an amputation in a diabetic foot had a foot ulcer before it happened. So we want to be screening actively for foot ulcers. We want to be making sure we don't miss a neuropathy so that they don't go on to develop an amputation. That's the big thing we want to prevent happening, right? That's what we're doctors for, to prevent things happening. So limb amputations in a population of 1,000 diabetics is about 0.5 to 5 per 1,000 diabetics. Obviously this increases the longer you've had diabetes as well, the incidence. So the other thing about a diabetic foot check that a doctor or a nurse does is that the patient is unaware. They're not aware that they have a foot ulcer. Often they have eye disease with diabetes. They can't see well. Or they have a neuropathy, so they don't feel anything. Or they just have poor self-care anyway. That's probably partly why they got diabetes maybe. Not always, but in some cases. So we need to be proactive. In the UK we have an annual foot check. And for those patients with a high risk of developing foot ulcers and neuropathy, it's a 6-monthly check. We increase the frequency we check them. See, these are the risk factors. So the risk factors for developing a diabetic foot problem includes peripheral arterial disease, that's where we want to check the pulses, peripheral neuropathy, and that's where we're going to check sensation in a minute. Is there any callus formation, the dry sort of rough skin on their foot? Is there a joint deformity? Is there Charcot's disease? What about the mobility as they came into the room? Have they got any problems with their mobility? What about the footwear? Is it old shoes, or they've just bought new shoes and they're rubbing against them? Do they smoke? Are they hypertensive? Have they got high cholesterol? These are all risk factors for vascular disease. And finally, what about their last HbA1c? What about their diabetic control? Is it well controlled? The two biggest things that you can make a difference in a diabetic's life is in improving their blood pressure and their sugar. And both are as important as each other. So, get my phone again, or we've got another volunteer? Is a good one. Sugar. Okay, this time I just need you to sit more. Yeah, time to relax again. So just extinguish just lift the showers as well. Make it form this hand. So it'll be better for you. So again, Oscar time. Say hi, my name's Dr. David, how are you? Praise Shrismak. I've come here to examine your feet. We've got diabetes, it's your annual check. Is that okay if you just expose your feet for me? And just not to lift up the lower parts of the trousers as well, just to look at the skin. You may go further just to check the pulses in the popliteal area if there's a problem with the pulses in the feet. Okay, so we've got the patient as we want to, we're going to wash our hands, we're going to keep the place nice and confidential and private, and then we're going to start the examination. And the first thing that I'm going to do is just look. I'm going to just have a look for the colour of his feet. So I'm going to check if there's any blueness, if there's any vascular insufficiency, any redness, erythema, signs of infection or anything like that. I'm going to just see if there's any black areas of gangrene perhaps, you know, with vascular insufficiency. So I'm just going to have a look. Is there any ulcers that I can see already as I look around? And then I'm going to also just check, particularly with vascular disease, see if there's any hair loss on the foot. That's one of the first things you lose with vascular insufficiency. And also look at its nails. You know, is there any nail dystrophy? Is there any fungal nail infection? That's a common cause, a common reason for having that with diabetes. Or is it thickened? Is there any problems with the nails? Now we're going to move on to looking at for callus formation. So actually, Matthew's got a slight bit of callus formation on the ridge of his first metatarsal, common area over the top of the dorsum of the toes. Wherever you've got contact with a shoe, that's often a place for callus formation, thickening of the skin. Other places you need to have a look under the heel as well, and just underneath the pad of the foot. These are common areas for callus formation, as well as at the tips of the toes. So you want to look everywhere for callus formation. When I'm looking for athlete's foot, fungal nail infection, where else do I need to definitely look? Where does fungal infection? Between the toes, the webbing. So you need to actually actively look for ulcers and athlete's foot between the toes. Very common to get it there. Okay? So then you move on to checking for ulcers. It's the same thing. You want to check everywhere. The same places for callus formation between the toes. You want to demonstrate that you're looking everywhere. Look underneath the heel as well, which you can miss if you don't lift up the leg. Okay? And it doesn't look like there's any sign of that. I'm doing that. And so then we're going to ask the patient to stand him up. Okay? So is it okay if I just stand you up? Okay, I'm just going to stand you on the floor here. And the reason for this is looking for Charcot's disease. So I want to look. Can I put your side on? You go side on for the audience. Yeah? No, just side on that. Yeah. So I'm looking at the. Just keep going. Okay. So I'm looking for the bridge of the foot. You know, has he got a flat foot? Which actually, it does have a bit of a flat foot. But you know, is there an arch, or is it collapsed down? And so then I'm looking over the top. Is there any redness over here, which you get with Charcot's disease? And also, you know, the architecture of the foot. You know, basically, this is all collapsed down, and the ankle joint looks okay, but it's just all collapsed down. That's what you're looking for. So you're looking for the arch of the foot and how the joint looks itself. Thank you, Mathan. Just sit you down. So this is just to say this is where the callus formation is, along here, tips of the toes. These are common places to get callus formation. Again, diabetic foot ulcers in the same places, wherever you've got friction. The pad of the foot, the bottom of the toes, the heel of the foot, the dorsal of the toes here. And you see this claw toe here? That's a risk factor for ulcers because it's rubbing against the shoe. Oops, vulnerable. This is what we're trying to prevent. What's this? Yeah, an infected foot ulcer. You see the erythema around here. It's got even a pen line on because obviously this patient's on antibiotics. They're going to probably check again in 48 hours to see whether the erythema is going less. It's going beyond the pen line. You worry about it tracking up the leg. Problems with antibiotic resistance is a big problem with foot ulcers. And if it's a deep ulcer and it infects the bone, even more difficult. With osteomyelitis, a very difficult problem to treat. And if you can't treat it well, then you're looking towards an amputation. And that's what we're trying to prevent. That's what we're trying to avoid. Okay. This is Charcot's disease. So this is normal. Then you get the loss of the bone structure, starts to get destroyed, and you get ulceration, particularly here. on the heel. And then you may get fractures as well, and so you lose the whole kind of normal architecture of the arch. You know, this is kind of all osteoporotic. It's sort of a loss of the defined joint. You see that? And it's flat as well. You see how flat that looks as well? It's lost its arch. Yeah. Then we move on to palpation. So we're going to use our fingers now. I'm going to just first of all check the temperature of the skin. Does it feel cold, normal, or hot? Okay, just go on the peripheries. It can be quite warm in neuropathy. It can be quite cold if you've got vascular insufficiency. So use the back of your hands, use the back of your fingers. The other thing we'll just check is the capillary refill time. Do you know how you check for that? Just a bit. So you're just going to press on the nail, let go. Does it go pink within 2 seconds? Alhamdulillah. Everything's fine. And so, and if it's more than 2 seconds, then you may think, right, what do I need to check for next? And that's something called a Berger's test. I don't know if you remember a Berger's test. Yeah, when you lift up the leg, yeah. So that's a capillary refill time. And then you're going to check the pulses. So you're going to check for the dorsalis pedis and the posterior tibialis. Dorsalis pedis, where's that? The front or the bottom? The top, yeah, it's dorsal, sorry. And where is it located? First third, second third. So first third between the two metatarsals, first and second. Use 3 fingers and just check for the dorsalis pedis. And then you're going to check for the posterior tibialis. Where's that? Medial or lateral malleolus? Medial, fantastic. You guys have been learning something. And check with 3 fingers. Yeah. And you're checking whether the pulse is there. Is it weak or is it absent? Okay. If it's weak or absent, then you may want to go on to do some Doppler studies, or a brachial, ankle brachial pressure index. Do you know what that is? Where they measure the pressure in the ankle, and then they measure the pressure in the brachial, and then you do an index. What's the ratio of the two? And depending on that, you can work out whether it's a venous problem or arterial problem. Okay. Now we're going to check for neuropathy. Now, in the UK we use a 10 gauge monofilament. I think that's used most around the world. Maybe Japan uses a slightly smaller one. For the exam, I don't know if you're going to have any of these, so it may be cotton wool, I'm afraid. But this is what we're supposed to use, a monofilament. And what you're trying to do is you're just trying to test different areas. There's about 10 areas, standardized areas you're checking in the foot. And what you do is you put it against the skin and it needs to bend. So when it bends, then that's, you know, you've done the right pressure. So I'm going to ask you, Mathanda, can you feel this?
Mm-hmm. Yes.
Okay. Yes. And then go on the pads, the back, and the heel. And one extra place is just between the webbing of the toes here. And you do this on both sides. So the first, the big toe, the third toe, the 5th toe, same areas underneath on the padding of the foot. And then 2 areas in the back and the very back of the heel. And then you just go on the top, the webbing of the 1st and 2nd toe. And that's on the diagram for you on the next slide. That's the monofilament testing. Okay? That's the place you're going to test for. One of the other sensations that first goes, we talked about the different types of nerve fibres. One of the first things that goes is vibration sense. So how do we test for vibration? How do we test for vibration? Maybe the tuning fork. And where do I put it? On his head? No? Do anyone know where you put the tuning fork when it's testing for vibration? It's the big toe. Okay, if you can feel it, then everything's okay. If he doesn't feel it, then you may go to the medial malleolus for higher off the testing. So I often just use the back of my shoe, put it on the toe. Can you feel that? Now, if you're not sure you can feel it, you may just wait until it completely disappears. Can you tell me when you feel the vibration disappears? So we might be here for a little while. That's okay. And I can feel it too, so I know when he's... Yeah. Okay, so that's a good way of just testing whether he's got good vibration. On the medial malleolus, again, you just go for the bony prominent just here, just on the medial malleolus if you need to. And that's just about it for the diabetic foot examination. Just to say, if you've got a patient you think is high risk, you're going to see them every 6 months. If you think they're low risk, medium risk, you just see them every year. You know, everyone should have a diabetic foot examination. We don't want to have patients having amputations. We want to pick up whether they've got vascular insufficiency or neuropathy or any signs of foot ulcers they've got to treat early and aggressively. Okay, so if high risk is if they've had a previous ulcer or amputation, or they have more than one risk factor. So that may be a loss of sensation when you're doing your testing of sensation, or they've got callus formation, or you feel that the pulses are absent or weak, or you see a deformity in the ankle itself. Yeah? So they're all risk. They're all sort of risk factors. If you've got 2 or more of those, then it's high risk. That's it. Finished. Class. Okay. I hope that was helpful. Thank you very much for your attention. Thank you, Madonna. Thank you very much. And next.